in the cheek embryo-chorioallantoic membrane, the equivalent of our placenta, and you see all the blood vessels that converge toward the center of the sponge. If I may have the next slide, I will show you the quantitative results. So in this sponge there are human breast cancer cells. Human breast cancer cells, they produce factors that attract new blood vessels. This has been known for the past 20 years. It's not a new discovery. But if you put Gcmaf inside the sponge together with the breast cancer cells, you see a decrease in the number of the blood vessels. The asterisk, they indicate the new blood vessels formed, and here you see a net decrease. You may wonder whether is this an effect of Gcmaf on the cancer cells, and the answer is yes. But also there is a direct effect of Gcmaf on angiogenesis, because if you put prostaglandin E1, that is no cells, but just the angiogenic factor in this sponge, you see absolutely the same result. So we can safely state that Gcmaf also has a direct effect on angiogenesis, that is, it inhibits angiogenesis. Yes, Mike?
Can you ask questions now or later?
Well, if you ask them later, I don't lose the logical progression of this presentation. Now, when a tumor has seen its angiogenesis blocked, of course, it is deprived of the energy and blood supply that is redirected to supply the normal tissues fighting cancer. And I think Dr. Smith will show you later on how starved and weakened cancer cells become easy prey for the macrophages activated by Gcmaf. May I have the next, please? This also tells us why is Gcmaf so effective in a variety of diseases that may have nothing to do with cancer, like neurological diseases. Because there are many diseases where angiogenesis or dysregulation of angiogenesis is an important pathogenetic factor, like Parkinson and Alzheimer, rheumatoid arthritis, chronic inflammation, in particular that's seen in myalgic encephalomyelitis or chronic fatigue syndrome, diabetic retinopathy. This is a typical scan of the temporal lobe that I hope you memorize, because you will see it in real time in Alzheimer's patients that can be affected by regulation of angiogenesis by Gcmaf. And then the reason for the ultrasound machine to be there, because about 2 years ago we discovered that Gcmaf, in addition to these that are called genetic effects, because imply transcription or inhibition of transcription of genes, also elicits rapid non-genomic responses through the VDR and cyclic AMP that can be measured in real time in individuals, assuming Gcmaf either as an injection or sublingual or other routes of administration. I will show you later on during the day or maybe tomorrow how these effects can be exploited to monitor the individual responsiveness to Gcmaf. As a matter of fact, it had been demonstrated in 2012 that the activation of the vitamin D receptor, which again is the target of Gcmaf, prevents fibrosis and diastolic dysfunction in a murine model of pressure overload. That is, it works on the heart. And we can measure now the so-called isovolumetric relaxation time, that it is an index of diastolic function under the influence of Gcmaf in real time in individual patients. Probably this worked through the VDR alternative pocket that I show you in the second slide at the molecular level, and it implicates the regulation of voltage gate chloride channels. So this is a typical slide that demonstrates what we are seeing. So this is the radial artery. No need to measure at the heart level. You can do this peripherically at the radial artery. So this is the isovolumetric relaxation time when you have an inotropic effect, and Gcmaf gives you an inotropic effect that prevents diastolic dysfunction. You see a shortening of this time from 100 or so milliseconds to much less. That can be measured, and then provide a statistically significant measure of Gcmaf effectiveness in vivo. These effects are mediated through the formation of a second messenger that is called cyclic AMP, and we demonstrated, actually we were the first to demonstrate that through its interaction with the VDR, Gcmaf stimulates the formation of cyclic AMP within seconds inside the cells in a VDR-dependent manner. This paper was published in 2012 by our research group in the Journal of Nephrology, and it demonstrates two things. One is that Gcmaf actually stimulates the formation of this important second messenger, which is called cyclic AMP, but also that we are not equal, and we knew this more or less. That is, according to the VDR gene polymorphism, some individuals have a higher responsiveness to Gcmaf and other individuals have a less pronounced response to Gcmaf. This will be important in the next slide, because today you will hear many doctors report excellent results treating with Gcmaf several different pathologies. This is the seminal paper published by Dr. Bradstreet and co-workers, where they demonstrate that they can eradicate the symptoms of autism in more than 15% of the population of children treated with Gcmaf. And of course we do rejoice for these successes. And we do rejoice for the successes in treating cancer at different stages. But we are very saddened that there is still a percentage of patients who do not respond to Gcmaf. And these patients are the focus of my research, because I feel the moral obligation to decrease this column so that the highest number of patients can respond to Gcmaf. So how can we decrease the column of patients who do not respond as yet to Gcmaf? Well, we can exploit our latest observation. That is, we can adopt what I call an integrated, individualized approach to Gcmaf treatment that takes into account the determination of the VDR polymorphism, the determination of the nutritional and inflammatory status through a score that we did not invent, but we rediscovered quite recently, the determination of the individual responsiveness to Gcmaf through the Doppler ultrasonography, echography, and the determination and follow-up of brain inflammation through transcranial ultrasonography that I will show you tomorrow. Now, the determination of the VDR gene polymorphism will lead to the so-called pharmacogenomic approach to Gcmaf. We presented these results at the World Congress of Nephrology in Vancouver in 2011, and we published the paper, as I said, in 2012, demonstrating that the assessment of the VDR polymorphism is a prerequisite to state whether a patient needs a certain amount of Gcmaf, more, less, more frequently, less frequently. So this is the modern concept of individualized medicine based on pharmacogenomics, because we all know that the responsiveness of all of us to any type of molecule is different, has to be different. And now we have the molecular tools, the genetic molecular tools to assess this responsiveness. Now, this looks complex, but it is not. This is something we published in 2012 in the American Journal of Immunology, where we studied the 62 cancer patients with late-stage cancer, and we discovered, or rediscovered, I must say, that the nutritional status is as important as the inflammatory status. These are common exams that are made in any analytical laboratory in the world, where you measure inflammation through these indexes here above, and you measure the nutritional status through these indexes here below. And you make a ratio, a number comes out, so something that is very objective, and according to this number, you can predict the mortality, you can predict the prognosis. But if you change, the beautiful thing of this is that you can change this ratio. Gcmaf works on the upper part by controlling and reducing inflammation, but you have to work on the lower part, that is the nutritional status. So you can go at the same stage of cancer advanced cancer with no therapy feasible, you can go from a survival of a few weeks to a survival of 5 years. And this is published in this paper, observing these 62 patients. This is to say, when I mention vitamin D, when I mention oleic acid, that without an adequate nutritional plan, Gcmaf can do little. Gcmaf or anything else can do little. So the adequate nutritional plan has to become part of this integrated approach to Gcmaf immunotherapy. Then I will skip on the ultrasound IVRT, isovolumetric relaxation time, give you a brief overview that we now can observe brain inflammation with the ultrasound, so very safe, simple, non-invasive technique, no ionizing radiations or nothing, and we can study the effects of Gcmaf on neurons. Dr. Morucci will show you the effects of Gcmaf on neurons later on. Now I anticipate that it affects the thickness of the cortex, the neuronal layer arrangement, the thickness of the meninges, the vascularization, that is inflammation of meninges and cortex, and the movements of the brain. We will go into detail this tomorrow. This is just to show you what we see on the echo machine. We go to a level of resolution of less than millimeters, so we can see the individual layers of the temporal cortex. Now, I'm close to the end. I hope I was not too boring. And what are the conclusions of this first talk and the future directions? Well, we know now, and we know the reason why, Gcmaf exerts many more effects than simply stimulating macrophages. So it goes well beyond immunotherapy. And the study of Gcmaf-induced gene expression in different cell types, in different tissues, in different pathological conditions, will help the further understanding of Gcmaf effects in different tissues and possibly to novel application in several pathologic conditions, but not only pathologic, unless we consider aging a pathology, which I don't, because we see that the effects of Gcmaf on neurons can counteract the effects of aging. Of course, in order to maximize the therapeutical or protective effects of Gcmaf, we need to develop an integrated approach that takes into account the PD score, the VGR gene polymorphism, and this will help maximizing the effects of Gcmaf in any individual patient. And the use of the ecographic techniques that we developed in the past 2 years will help to monitor this effect, because these are simple and non-invasive methods. This was supposed to be my last slide, where I described that Gcmaf will soon be, or already is, available in different forms, in addition to the extremely high quality, high potency injectable version that you already know. There will be food-based Gcmaf. Gcmaf for topical use as a mouthwash for dentists or as an ointment, and other types of administration. So this was supposed to be my last slide when I prepared this talk 2 days ago. But 2 days ago, no, actually yesterday, just before boarding the plane, I received an email, and I could not abstain from presenting this email to you. It is in Italian because this is an Italian patient. This Italian patient has chronic hepatitis B. Has been infected since his childhood with hepatitis B virus, and eventually he developed cirrhosis.